Zoll LifeVest is a proud sponsor of CardioNerds. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Hi, my name is Dr. Shika Jha, and I am a fellow physician at University of Wisconsin-Madison Cardiovascular Medicine Department and a CardioNerds serving as FIT ambassador for the same. The American Heart Association Scientific Sessions 2024 will take place in Chicago from November 16 to 18 of this year, with pre-session symposia and early career day on November 15. It's American Heart Association's 100th birthday, and we will be covering exciting topics like immunology, AI, and new scientific guidelines. The CardioNerds Conference scholars will be in attendance, so register today at scientificsessions.org. Thank you.
And when registering, be sure to use the code NERDS, because if you're among the first 20 to sign up, you'll receive a free 1-year AHA professional membership. And with that, let's get to the show.
Hi everyone, this is Dinu Balanescu, cardiology fellow at Mayo Clinic, Rochester. We're thrilled to bring you another episode in the Beyond the Board series, today focusing on channelopathies. Channeling our efforts today are Dr. Natasha Vedage and Dr. Sonu Abraham. Natasha is a third-year cardiology fellow completing the physician-scientist pathway at Temple University Hospital in Philadelphia. And this summer, Natasha is electrified to move to Boston to begin her clinical electrophysiology fellowship at the Massachusetts General Hospital. Hi, Natasha.
Thank you, Dinu. Even as an incoming EP fellow, I feel like channelopathies can be intimidating at first glance. I know I'm really excited to dive into this topic and break it down, and I feel like this is going to be super valuable for all of our listeners. I have the pleasure of introducing Dr. Sonu Abraham. Sonu is from Chicago, where she recently completed her fellowship in advanced heart failure and transplant cardiology at Northwestern University. She will be at the University of Kentucky next year. Congrats, Sonu.
Thanks, Natasha. I'm really happy to be here and agree this episode will be a fantastic review of the most challenging topic, and not to mention a high yield for the boards. It is my distinct pleasure to introduce Dr. Michael Ackerman. Dr. Ackerman is a Mayo Clinic lifer. He completed his MD and PhD in molecular pharmacology at the Mayo Clinic in Rochester, Minnesota. He subsequently completed his residency at the Mayo Clinic in pediatric and adolescent medicine. Afterwards, he completed a postdoctoral fellowship investigating the molecular underpinnings of long QT syndrome. He then completed his clinical fellowship in pediatric cardiology. Dr. Ackerman is a genetic cardiologist and professor of medicine, pediatrics, and pharmacology at the Mayo Clinic, Rochester. He serves as the director of the Mayo Clinic Wendland Smith Rice Sudden Death Genomic Laboratory. We are honored to have you join us today, Dr. Ackerman.
Sonu, great to get to be with the three of you. I'm thrilled to have a debut with you all on Beyond the Boards.
I'd love to kick things off with a case that I recently encountered in the cardiology clinic at CardioNerds Medical Center. John Abraham, he is a 39-year-old male with no past medical history. He was noted to have an abnormal EKG during an annual checkup with his primary care physician and was referred to cardiology for further evaluation. John is otherwise a pretty healthy guy. He exercises regularly and is asymptomatic, so no chest pain, shortness of breath, pre-syncope or syncope, and no signs or symptoms of heart failure. He was adopted, and his biological family is unknown. Closer inspection of his EKG in our clinic, placed in a standard fashion, shows that he has this distinct pattern in V2. There's a ST elevation with a sharp downslope, which we recognize to be the type 1 Brugada ECG pattern. This seems concerning, although my patient is asymptomatic. Dr. Ackerman, is this EKG pattern alone sufficient to clinch the diagnosis of Brugada syndrome?
It's a great question, Natasha, and there's sort of be a raging debate across the globe as to whether a one-time ECG that shows that so-called type 1 Brugada ECG pattern, if the ECG pattern is equal to Brugada syndrome. The Shanghai criteria, which we helped develop several years ago now, would say no, that is not enough to reach a Shanghai score, if you will, for the diagnosis of the syndrome. It's a pattern worthy of careful investigation. It may be a pattern worthy of an ECG surveillance in first-degree relatives, additional testing in John the patient, potentially genetic testing for John. But I and many individuals in the field of genetic arrhythmia syndromes would not equate the ECG to the diagnosis of the syndrome called Brugada syndrome.
Excellent. Thank you, Dr. Ackerman. So having a patient with EKG findings compatible with Brugada syndrome alone is not sufficient. We need to elicit additional details from their history, whether they have syncope, maybe a family history of known Brugada, or had positive genetic testing. Speaking of genetic testing, Dr. Ackerman, could you tell us what are the primary mutations we are screening for, and what is the diagnostic yield of such testing?
Yeah, I would love to, Sonu. And actually, there have been 23 alleged Brugada syndrome susceptibility genes that are in the public domain, published with varying levels of evidence. And over the years, there's been an effort to do sort of disease gene purification. And an entity called ClinGen has weighed in and assigned what is the strength of evidence, what's the veracity of the disease gene associations. And as it turns out, this was published in Circulation a couple of years ago, that every Brugada syndrome susceptibility gene has been demoted to limited evidence, insufficient evidence, except one, the original Brugada gene, which involves mutations in the SCN5A encoded NAV 1.5 sodium channel, so the SCN5A gene. So from a monogenetic Brugada syndrome basis, only true loss of function mutations in the SCN5A gene would be sort of Brugada disease or Brugada syndrome worthy. And even there, one has to be careful because there's some concordance violations between the relatives potentially. So if you have a patient, Sonu, who you have no doubt clinically is Brugada syndrome, and you order the Brugada syndrome mutation spell checker, and otherwise known as the Brugada syndrome genetic test, that genetic test, commercially available, will still contain almost all of those previously published genes. They haven't been removed from the hit list, but your focus should be on whether or not there's a bona fide loss of function mutation in the original Brugada gene, SCN5A. And that answer is you have a definite patient. What's the likelihood that he or she will be SCN5A positive? In other words, what's the yield of the Brugada syndrome genetic test is 20%. And as it turns out, we can do better than saying 20% because it's really 40% if the patient has the Brugada pattern that we mentioned for John and has a prolonged PR interval. Now, if the patient's PR interval is instead normal, then the a priori likelihood of being SCN5A positive drops to less than 10%.
Wow, that makes a lot of sense that mutations in a sodium channel would also present with other conduction system abnormalities. And aside from that classic EKG pattern that we learned for Fords, we should also be clinically screening for things like first-degree AV delay, which we encounter commonly. And that's a really impressive increase in diagnostic yield when the PR prolongation is present. So thank you for sharing that pearl with us. I did want to circle back to our patient. So we've identified that he is asymptomatic. He has spontaneous EKG findings consistent with type 1 Brugada pattern. Family history is unknown, and genetic testing has not yet been performed. Now, I'm not saying this because I am an EP-bound fellow, but I'm keen to bring this patient potentially into the lab. Dr. Ackerman, how do I know if he would benefit from a prophylactic ICD? Maybe is it possible that you can do something like programmed electrical stimulation and see if there's VF inducibility. Would this help me risk stratify my patient?
Yeah, I love that question, Natasha. And just like the ECG pattern would yield an interesting debate across the globe, the question of whether should we or should we not do an EP study for further risk stratification, and if yes, what kind of study, and if positive, are we now obligated to provide a prophylactic ICD? And so that answer is actually a little bit more challenging because I find that it depends on the patient. What kind of emotional baggage have they brought into the visit? Have they already Googled Brugada syndrome and sentenced themselves emotionally to sudden death during sleep on this upcoming nights of sleep? Or are they pretty comfortable and relaxed about everything? And the reason why I think the EP study for further risk stratification is arguably optional is we don't know enough about him yet. Now, family history, like you said, is not available. You can do other things for risk stratification in staring at his ECG. Is the QRS complexes, are those complexes nice and smooth everywhere? Or are they ratchety, fragmented QRS signals? Turns out that QRS fragmentation may be almost as good of a risk stratifier as the EP study itself. Now, we really don't need doing an agmaline challenge or a sodium channel blocker challenge, agmaline in Europe and Asia, flecainide most commonly in the United States, because we already have seen the pattern. So if the pattern is even more there with the drug challenge, doesn't matter, doesn't move the needle. What will move the needle is, I think, the genetic test. Are we dealing with SCN5A mediated Brugada ECG pattern? That's now called Brugada syndrome subtype 1, the genetic version of Brugada syndrome. And certain mutations may be more arrhythmogenic than others intrinsically. So I do think this patient needs to be genetically tested. But then should he have the EP study? More and more, I have found that the answer can be yes, and should be yes rather than no. In the past, it was viewed, the EP study was viewed as misleading, false positives, not helpful, don't do it. Now I would say a more careful review of the meta-analysis would say if you do the EP study the right way, and that would be a double stimulation protocol, RV Apex, rather than one of those aggressive triple stimulation protocols where you can get anybody's heart to go into VF. So you have to, as an EP physician, constrain yourself. Don't do the triples, because if you do the triples and you induce VF, it's really hard to step back and say, well, that was nonspecific. We don't need to act on that. So double stimulation protocol, and if positive, then this meta-analysis studies would suggest that that patient's annualized risk is about 1.5% chance per year of an ICD-worthy event. Whereas if negative, that provides further reassurance of low risk and lowers the risk to around 0.5% chance per year, for which there's no disease currently in cardiology where that residual threshold of risk is deemed ICD worthy from a primary prevention ICD perspective.
Wow. So there are really a lot of nuances with regards to pursuing an EP study, especially with emerging data. And since careful EKG review and genetic testing can provide further risk stratification and guidance regarding the ICD. There are consensus recommendations out there too, though. Brugada syndrome plus history of cardiac arrest, sustained VT, or even syncope judged to be caused by ventricular arrhythmia would warrant an ICD. But what about pharmacologic treatments for Brugada syndrome? Is there a specific subset of these patients where medications can actually be useful?
Absolutely. And there's currently only one medication available for Brugada syndrome, Dinu, and that is quinidine. So one of the oldest antiarrhythmic drugs we have is making a comeback and that's for the treatment of Brugada syndrome. Now, quinidine is really an interesting story with Brugada syndrome, isn't it? Because if you think about it, quinidine is what kind of an antiarrhythmic drug in the Vaughan Williams classification, right? Anyone? It's a class 1 agent. And you say, wait a second, a class 1 agent is a sodium channel blocker. And we're using class 1 agent, ashmolein, flecainide, procainamide, as the Brugada elicitor, the drug challenge test for diagnosis. So why would we be using quinidine for therapy? And it turns out that it's not quinidine's 1A activity that we're using. It's the fact that quinidine is a multi-channel blocker. And in fact, it's quinidine's ITO blockade of the KCND3 encoded ITO potassium channel that mediates phase 1 repolarization, that when you block it, you restore the balance between the sodium channel reduction from the mutation and the relative overabundance of ITO activity. And so it's really quinidine's ITO activity that is part of its direct mechanism of action. And now quinidine in some countries, Israel in particular, would be used as the treatment of choice for the symptomatic Brugada patient where his or her symptom was syncope. I think everybody agrees that if you do Brugada syndrome triggered cardiac arrest, that's a straight line to a secondary prevention ICD, and the guidelines support that. The guidelines kind of say that if you did syncope in a way that you and I thought was a rhythmic syncope, then that brings you to an ICD. Now, that's a true statement. That's often done, but primary therapy with quinidine would be an option as well. For sure, quinidine's place is in the Brugada patient with symptoms, with an ICD, with recurrent appropriate Brugada-triggered arrhythmias resulting in a shock. So then often we'll add quinidine, and we used to have that as our only option until the option of back to the EP lab, but now for the purpose of RV outflow tract epicardial ablation to provide additional therapeutic efficacy is another treatment option. So right now, the only drug that has therapeutic potential in Brugada syndrome is quinidine.
Thank you for sharing that, Dr. Ackerman. And I would be remiss if I wouldn't mention that when I was rounding on the EP service with Dr. Sam Asirvatham, he did mention that the classification of antiarrhythmics is more or less random. They actually all inhibit multiple types of ion channels, and it comes as no surprise that quinidine's effect in Brugada is not related to its sodium channel blockade effect. So that was such a fantastic overview of Brugada syndrome, and we learned a lot from that case. But it does bring to mind another case that I saw recently, except unlike our first case, this patient presented after a concerning syncope episode. So this is Jessica Mira, a 21-year-old woman who was referred to the CardioNerds clinic after she had a syncope while running on a treadmill at her local gym. This event was witnessed by a staff member who noted seizure-like activity associated with this fainting episode. She fortunately did not sustain any significant injuries, but was nonetheless alarmed by the episode, and rightfully so. So in the clinic, we performed a baseline EKG that showed a normal sinus rhythm, normal intervals, including the QTC interval, and a baseline transthoracic echo was ordered, which showed normal biventricular function and no significant valve disease. So Dr. Ackerman, what are your thoughts about this patient? Her QTC is normal. She has no structural heart disease. Should we just send her home and stop there?
Well, Dinu, unfortunately, sending her home and stop there is what's happening all across the country and all across the world all the time. And hopefully this effort of yours and my participation can change that, because we have to do something better. We see this all the time after exertional syncope, that they just do an ECG. I'm surprised your patient got an echo. Often it's just an ECG. ECG is normal. The emergency department says, oh, you might have been a little bit dehydrated that day. Just we'll give you one exertional faint on the house. And where we see this worse is the sudden cardiac arrest survivor who comes in not to your clinic, but into the ICU and gets a full workup, except gets the defibrillator without the accept. And what I'm talking about is exertional syncope on a treadmill is a penalty faint. That penalty faint demands a comprehensive evaluation before dismissal. And that comprehensive evaluation is not an ECG and an echo only. It has to be 4 things minimum: ECG, echo, and then most importantly, when the ECG and the echo are normal, is a stress test, a treadmill stress test. And then the 4th item that we do is a Holter, because in this case, with this setup, the normal ECG exertional syncope person is far more likely to be a different channelopathy called catecholaminergic polymorphic ventricular tachycardia, or CPVT, rather than calling her, I wonder if you are normal ECG long QT syndrome. No way. Because normal ECG long QT syndrome doesn't do a sudden worrisome faint on a treadmill. Almost never. So you gotta think CPVT when the ECG is normal. And by thinking it, you can order the right test. And it turns out, as we published several years ago now, the average delay from first worrisome symptom, like Jessica's, to correct diagnosis of CPVT is over 18 months.
Wow, that's an incredibly long time. And I can imagine that this patient population, who is seemingly young and healthy, can get easily dismissed. So I think one of my takeaways from cardiology fellowship was exercise stress testing provides a wealth of information. So it's great to hear that this could also help us with diagnosing another arrhythmic syndrome, CPVT. So our patient actually did undergo exercise stress testing. At peak exercise, she was noted to have ventricular bigeminy, which quickly resolved while she was in recovery. We didn't observe, this hallmark arrhythmia of bidirectional VT, which we're taught sort of classically goes along with CPVT, where you have this alternating QRS axis B to B. Does this mean that CPVT is ruled out, or how do we interpret that she's had some ectopy at peak exercise? Is that helpful?
Yeah, Natasha, that's a really important question and distinction, because the board's answer and the hallmark trademark dysrhythmia of CPVT is, as you said, exercise-associated bidirectional VT, where, as we know, there's one real, I would say, pharmacological copycat of that profile, and that's digoxin toxicity. And so what we're really dealing with is that's an arrhythmia that emerges from intracellular diastolic calcium overload. Now, the problem with that trademark correct board's answer bidirectional VT is it is specific as long as there's no digoxin toxicity, but it is incredibly insensitive. So I take care of probably 200 to 300 patients of CPVT. Now, the number who have provided Exhibit A, bidirectional VT, is less than 5 of my fingers out of those 200 and some patients. So you will miss a lot of cases of CPVT if you require them to show you Exhibit A. Now, what you described is also, however, not typical of CPVT. So one would have to really carefully look at that stress test, because if the ventricular bigeminy only came out at peak exercise, that's unusual for CPVT. What's more characteristic is that the rhythm is completely normal at rest, heart rates 60, 70, 80, stage 1, normal heart rate 100 or so. And then the ectopy comes out like hide and seek, come out wherever you are, when the heart rate reaches about 110 to 120. And it typically comes out as a single PVC on the screen. And then with increasing heart rates, the single PVCs increase in frequency and then starts PVCs in bigeminy. And then that PVCs and bigeminy may deteriorate to couplets. And for bonus points, it might show you the bidirectional couplet. But you don't need to wait for non-sustained VT of any nature, bidirectional or not. And what then often happens in a CPVT patient, they might get to their final 10 beats per minute of their maximum heart rate, say heart rate 160 to 175, and then all of that ectopy vanishes. Now, if it stayed there throughout the exercise, it typically vanishes within 30 seconds of the recovery phase. And so I would want to see, were there some pre-bigeminal PVCs that were starting to come out, and then it escalated to bigeminal PVCs, and then it went away? If so, that's plenty of pre-genetic test suspicion for CPVT. I for sure would then move on to CPVT genetic testing, taking careful family history and so forth. But for sure, that would be a class 1 indication to proceed with CPVT genetic testing.
That was excellent, Dr. Ackerman. So just looking back at this patient's strips, it does look like the patient has some PVCs that started right after stage 1 and then deteriorated to the ventricular bigeminy that we mentioned earlier. So it is very possible, like you said, that this patient might have a diagnosis of CPVT, and he then went on to get genetic testing. And let's say that we make a diagnosis of CPVT in this patient. Dr. Ackerman, how would you counsel this patient, and what therapeutic interventions should we offer her at this time? And when, if at all, is an ICD appropriate?
Yeah, really good questions, Dinu. And here, I think one key thing is now you and I have made the clinical diagnosis of CPVT, and that phenotypic designation is super important when you do the genetic test, because when you do the genetic test in that context, often a mutation in the most common CPVT susceptibility gene, RYR2, that builds the heart's ryanodine receptor subtype 2, that test report will come back to you and me, Sonu, saying a VUS, a variant of uncertain significance. And that's a problem with the fact that that gene is so large, one of the largest genes in the human genome, that there's just not enough in silico analytical ability to grade those variants. But we don't need that. If the company told us it was a VUS, but you and I had already said the patient is CPVT, that gives us the phenotypic strength to upgrade that variant from a clinical genetic test company's designation as a VUS to a CPVT1 causative variant. So we can do what we call phenotype enhanced variant adjudication. The point there being, now we have a tool to then assess the rest of the family members with variant specific cascade screening. But now for Jessica, she is clinically suspicious for CPVT. Her stress test fits with CPVT. Her genetic test shows a CPVT variant. She needs to be on a CPVT1 directed treatment program. That CPVT1 directed treatment program for her portal of entry, a concerning faint, but while undiagnosed and untreated, is not an ICD. And here's another problem that Natasha will encounter in her fellowship is EP physicians, I love them, but the channelopathies are so far outside the sweet spot of the vast majority of heart rhythm specialists that we have an incredible over-implantation of ICDs going on, kind of like the saying, if it looks like a nail, hammer it. And here, doing a defibrillator for her would be a big mistake. The guidelines now make it clear that syncope as the portal of entry should not prompt an ICD. We need to get her on a good treatment program. That used to be beta blockers only, preferably the non-selectives of Nadolol or propranolol. And we used to do beta blocker therapy only a lot, but I would say now the standard of care would be combination drug therapy with beta blocker, nadolol, plus flecainide, a class 1C sodium channel blocker. And then what we do is we titrate those medicines with the goal of quote unquote curing the stress test, meaning on therapy, does it become impossible to suspect the diagnosis of CPVT? Have we gotten rid of the exercise-associated ventricular ectopy? And if they're not tolerating the medication, then we have a beta blocker alternative strategy of left cardiac sympathetic denervation surgery. But we try really hard not to use an ICD in CPVT, and we never use the ICD by itself. Whereas the first patient, John, if we had elected to give him an ICD because we didn't like his EP study or for whatever reason, his case, we would start with an ICD all by itself. CPVT and ICD should never, ever be used as monotherapy. And in Jessica's case, she doesn't even need an ICD. And likely, if we do it right, we'll never need an ICD.
That was a brilliant overview, Dr. Ackerman. Truly, medical therapy is the mainstay of treatment in CPVT. ICD is, like you said, not the answer. And in all of our patients with an exercise-triggered event, we will do an exercise stress test, as this is the key to early diagnosis of CPVT. Dr. Ackerman, we are learning so many useful clinical calls today. We did have one more case we'd like to run by you. Susie Alden is a 35-year-old female with no significant past medical history who's referred to cardiology after she was noted to have a prolonged QTC on routine EKG. She denies any symptoms and has never experienced any pre-syncopy or syncope. When taking a family history, she discloses that her father passed away suddenly in his sleep. He was 38 years old and his cause of death was unknown. We perform an EKG in clinic and the reported QTC is prolonged at 5-10 milliseconds. Oftentimes, we do an eyeball test to see if the QT interval appears prolonged, that is greater than half of the RR interval. Dr. Ackerman, generally speaking, how good are we as physicians at correctly recognizing long QT intervals?
I think it depends, Sonu, as to whose eyes and whose brain between the eyes are staring at the ECG. So it turns out that for the purpose of QT vetting, that the computers is not bad. Not great, but not bad. The computer probably gets the QTC right about 90% of the time, maybe a little bit higher. It just turns out that when it misses it, it can really miss it if it got fooled by the offset of the T wave for whatever reason, or the low amplitude T waves fooled the computer. As it turns out, Sammy Viskin, a good friend of mine, published now many years ago showing if the computer is not great or not perfect, the cardiologists are worse. So, and even heart rhythm specialists aren't that great at confirming the veracity or accuracy of the QTC. So we have work to do. It's honestly not that hard. It takes just a little bit of work to do the manual confirmation. And you mentioned one, the eyeball test of asking the question, is the QT interval more than half of the preceding RR interval? If yes, then the rate correction formula will always calculate to greater than 460 milliseconds. That doesn't equal long QT syndrome. That just is the eyeball test for above or below 460 milliseconds. I think what we try to convey is that the way you and I should do the manual confirmation is we do our eyeball test or the caliper test on the rhythm strip of lead 2 or V5 and see is our QT interval agreeing with the computer's absolute QT interval. If yes, you can say I've confirmed because the computer knows how to do mathematics and it knows how to do the RR interval quite accurately for the most part. But if your QT is disagreeing with the computer's QT, then you have to ask yourself why. Whose QT is right? Did one of us include the U wave? Did one of us exclude it? Did one of us exclude the bifid notch T wave and the other did not? So we have to have an accounting for why are we having QT discordance between your eyes, your caliper, and what the computer said. And then you do your due diligence once you have determined the absolute QT interval. In her case, in Susie's case, an incidental QTC of 510 milliseconds, with or without her father's tragic death, is a penalty box QTC finding, meaning you can't just blow that off and say, oh, whatever, we just stumbled into this. Anytime you find a QTC at rest at or above 500, we have to figure out the why. Is there an exogenous QT aggravating factor present in her body? A medication she's consuming, a supplement she's consuming, a medical condition that she has that has QT prolongation as a byproduct of the disease process? Is there an electrolyte abnormality? We have to explain that QTC value. And if we don't have an exogenous acquired reason for her QT prolongation, then we need to start wondering, did we stumble into long QT syndrome, albeit incidentally at age 35? Now, her father's story changes the game completely. Sudden death in a father during sleep at age 38, 510 for a female daughter. And you start to put the bet a priori that I wonder if I had a chance to stare at the ECG, would I be seeing not just the length of repolarization being prolonged, that is the QTC, but would I be bothered by the look of repolarization? Meaning, what does the T-wave architecture look like? And I would be betting, and as you know, I didn't see any of these cases beforehand, but I would be betting that Susie's T-waves have a bifid or a notching kind of contour in the lateral precordial leads of V4 and V5, and maybe even a low amplitude humped T-wave in limb lead 2, making you and I think that she and her dad may well have congenital type 2 long QT syndrome or LQT2.
I love that parallel back to Brugada, where we talked about how notching in the QRS and sort of disruption in ventricular conduction could be helpful in diagnosing maybe patients that are more prone to malignant arrhythmias. So it's really interesting to think about that in terms of repolarization in the T wave.
Yeah, I love that comparison. I hadn't quite thought of QRS fragmentation notching and T-wave notching in that way. So I'll thank you for that, Natasha.
Dr. Ackerman, those were incredibly useful tips for identifying prolonged QT, and I'll be putting that to use as soon as possible. But back to the case, we measured her QTC and confirmed that it was indeed prolonged at 510 milliseconds. We then performed genetic testing, which returned positive for the long QT3 genotype. Your team at the Mayo Clinic has led research efforts which has identified new genetic variants responsible for long QT syndrome. Despite this growing number of genetic variants, are there key genetic variants that are frequently culprit in genetically confirmed long QT syndrome?
Yeah, there is, Sonu. And you know, I had mentioned that I was wondering if there would be LQT2 looking T waves, but there's nothing more confirming than the genetic test itself. And so in her case, if it yielded a bona fide LQT3 causative variant, then we now get to think of her as having SCN5A mediated long QT syndrome or LQT3. And earlier we started talking about John doing Brugada syndrome testing to look for SCN5A mediated loss of function. So the sodium channel is fascinating. Depending on how it's damaged, loss of function brings you towards conduction disease and Brugada syndrome. Leaky sodium channels, where that instantaneous and enormous peak inward sodium current doesn't completely inactivate, and it results in a dribblage of low amplitude inward current throughout the action potential duration or late sodium current, that version of SCN5A damage gives you LQT3. And with long QT syndrome, the beauty of that syndrome is compared to every channelopathy and every heritable cardiomyopathy, the yield of the genetic test is the greatest. There's not really a close second, actually. So in other words, if you, Sonu, and I thought that Susie had long QT syndrome by her ECG, by the story, and now we order the genetic test, that genetic test will come back positive, not 20% of the time, like we mentioned for Brugada earlier, or 60 to 65% of the time if we thought it was CPVT, like in case 2, it will come back positive 75, 80, and probably now 80 to 90% of the time. So the vast majority of correctly diagnosed long QT syndrome is genetically findable long QT syndrome, where the yield is on the order of 80 to 90%. And most of that 80 to 90% remains the big 3 genes that were discovered in 1995 for LQT2 and 3 was first published in 95, and the LQT1 gene was first published in 1996. But those 3 genes, the big 3, LQT1, KCNQ1, loss of function, LQT2, KCNH2, loss of function, or LQT3, SCN5A, leaky sodium current, gain of function, accounts for about 80% at least of all long QT syndrome. Now, there's a lot of minor genes, Sonu. We have published most of the minor genes. Now, we have the numbering system going up to LQT4 to 17, but that numbering system probably needs to go away. We can keep LQT1, 2, and 3 because we know so much about the patterns, the genotype-phenotype relationships. But if I told you that my patient had LQT11, you would not necessarily quickly know, or should you need to know, that that would be ACAP9-mediated long QT syndrome, or LQT9 being caveolin-3 long QT syndrome, or LQT17 being triadin-mediated long QT syndrome. So we and others have advocated that if our patient happens to be minor genotype long QT syndrome, everything besides LQT1, 2, and 3, we should name it by the mechanism, by the disease gene. So caveolin long QT syndrome, calmodulin-mediated long QT syndrome. Because now when I say that, that will mean something to Natasha during her awards at MGH. So LQT1, 2, and 3, the most common. Minor genes, maybe the collection of all minor genes gets us another 3, 4, 5% bonus points. And the beauty of that awareness is you and I can still have a patient who truly is long QT syndrome, but is genotype negative. That will be true 10% of the time. But there are so many cases out there that the diagnosis in the first place was flimsy. And now they are genotype negative, negative genetic test. A negative genetic test in that setting, not in Susie's case, but in that setting, needs to prompt all of us to do a timeout and say, does this patient even have long QT syndrome in the first place? Because the objective diagnostic test called genetic testing that rules out 80 to 90% of the disease all by itself came back negative. So I always would recommend that a patient with negative genetic tests should have a very careful reevaluation to say, am I really convinced in the veracity of the clinical phenotypic diagnosis in the first place?
Wow, Dr. Ackerman, what a great overview. And let's just pause and rewind for a second. So there are 3 predominant long QT genotypes. At the same time, there are a bunch of minor genotype long QT syndrome. There's negative genetic testing long QT syndrome. But especially when we talk about the 3 main genotypes, are there any clinical hints that might help us make a diagnosis before genetic testing? Are there any specific triggers that might help us point to one or the other, or even one of the minor genotypes once we do get genetic testing?
Yeah, Dinu, I think there are, and they're really important for you and I to commit ourselves to making a pre-genetic test prediction. It's not just an academic fun exercise. It is fun, but it's actually helpful because if you and I clinically said, as we sized up Susie and said, she has prolonged QT interval, she has a very long isoelectric ST segment, but perfectly normal looking T waves, I'm going to bet she's LQT3. And now the genetic test comes back finding a variant in the SCN5A LQT3 gene. And again, the company, they were only able to call it a VUS. Well, you and I can now do phenotype enhanced VUS promotion. So committing ourselves to an understanding of the genotype phenotype relationships in long QT syndrome is not just an academic exercise, it's actually clinically very helpful. And so there are some. You and I start with the story. Was the story LQT1 suspicious, exercise swimming, or was it LQT2 suspicious, emotional triggered, alarm clock? Did it happen during sleep with no particular trigger, LQT3 suspicious? And then we get the ECG and now we stare at the T waves, not the length, but the look of repolarization. Were the T waves broad-based, LQT1 suspicious, or were they low amplitude, humped and bumped and notched in the precordial leads, LQT2 looking, or were they the completely normal T wave inscribed after a long isoelectric ST segment, LQT3 looking? And so that can help you and I anticipate, predict the genetic answer. And then when it all comes together in concordance, long QT syndrome is first and for a long time one of the only genetic arrhythmia syndromes, the only genetic channelopathies, cardiomyopathies, where we have genotype-based risk stratification. We have also genotype-dependent or genotype-guided treatment strategies where we absolutely treat LQT1 with a fundamentally different strategy, for example, than LQT2 and LQT3. Our thresholds for an ICD are different. Our non-beta blocker additional therapies are different based upon genotypes. The value and the role of denervation surgery works far better in LQT1 than it does in LQT3, for example. And so genotype-guided treatment is really an exciting part in the realm of the channelopathy of the long QT syndromes.
Wow, that's super interesting. And it makes me think that the approach to therapy has to be so nuanced. And even if we think about some of those minor phenotypes and probably the differences in beta blocker responsiveness, and like you said, if you're trying to block sympathetic drive, how do you kind of tease that out? Or do most LQT1, LQT2, and LQT3 typically have sort of characteristic responsiveness to the typical therapies that we think about? How do you approach treating long QT syndrome, and when, if at all, is an ICD warranted?
Yeah, for Susie, for example, Natasha, her therapy has changed over the years. In the past, it sort of was universal beta blocker therapy, again, starting with the non-selective beta blocker of nadolol or propranolol, avoiding, don't use metoprolol or atenolol. And so it was sort of beta blockers for all genotypes. And we know that there is genotype-dependent therapeutic efficacy. The beta blockers work much better in LQT1, quite good in LQT2, works in LQT3, but not as good as in LQT1. And so in LQT1 patient, not Susie, we generally start with a beta blocker and we up titrate it until we get into the dose range we're looking for in terms of a heart rate signal on stress testing or side effects. the downside of the beta blocker is there's nothing that you and I can look at to say, wow, we are modifying the problem, the phenotype, the QT number. Whereas in LQT3, it's now becoming a lot easier because more and more we are leaving the beta blocker, or if we're using the beta blocker, we almost always now use propranolol for LQT3 instead of nadolol, because besides being a non-selective beta blocker, propranolol has late sodium current blocking activity. In other words, it's a weak lidocaine. It's a weak mixilotine drug. So we will tend to start with propranolol for Susie, and we can actually look to see, is her QT interval shortening with propranolol? Not because of its beta blocker activity, but because of its weak mixilotine activity. And if we're not really seeing QT shortening, or if she's not liking beta blocker side effects, we could add mixilotine or shift to mixilotine all by itself therapy. So mixilotine monotherapy is becoming a more common treatment strategy for a patient like Susie. She needs to be treated. 35 symptom-free years doesn't mean she is low risk, not with a QTC above 500. So her risk is obviously low because she's been symptom-free for 35 years, but not low enough to say, let's just do no therapy, or what we call INT, intentional non-therapy, with QT preventative measures only. I think Susie needs to be treated. I would likely be starting her on propranolol, but being very comfortable with the idea of getting her shifted to mixilotine only therapy.
I think the concept of beta blocker responsiveness in these phenotypes is really interesting. Is it a dose-dependent effect that we're seeing? Like, is it that with certain genotypes that we need to saturate more beta blocker receptors, or is it just that on a molecular level, these are just doing fundamentally different things?
Yeah, it's really the latter, Natasha. The beta blocker doesn't really shorten the QT interval. I think that's been a misnomer out there. What the beta blocker may do, it kind of gives an illusion of shortening. And what I would mean by that, in an LQT1 patient, let's say an LQT1 patient got diagnosed with his or her resting heart rate in the 70s. And now on beta blocker, their resting heart rate is in the 50s. Well, we just have moved them into a range of less maladaptive QT-RR behavior. And so it gives the appearance that we have fixed or improved the QT interval. But if you put that patient on the stress test with LQT1, the maladaptive QT reactivity during the recovery phase of the stress test will rear its head just fine while on the beta blocker. So I think the true QT modification doesn't happen with the beta blocker. So I think of it more as your long QT mutation, LQT1, 2, or 3, that's flammable fuel. But in order for flammable fuel to get ignited and explode, it needs to get activated. It needs to get sparked by a trigger. That trigger in LQT1 is adrenaline. And so what is the beta blocker doing? It's really not decreasing the fuel's flammability. It's just putting a spark retardant around the fuel so that the sparks of life don't really reach the fuel. And that's what denervation surgery is doing so effectively. Denervation, unilateral left sympathetic denervation, is really an ablator or reducer of localized norepinephrine release to the LV myocardium, so reducing the sparks. Mixilotine, on the other hand, is changing the fuel's flammability. So we know that for every 10 milliseconds that you increase the QT interval, the fuel is more flammable. Every 10 milliseconds that you shorten the QT interval, the fuel is less flammable. And so with mixilotine, and we did that today with a patient who came and saw me today from China, a beautiful little girl, we are up titrating her mixilotine because it was used completely wrong. 50 milligrams twice a day. Mixilotine is not, never was a twice a day drug unless the patient is an ultra poor CYP2D6 genotype, a poor metabolizer of mixilotine? And if so, we could exploit that to our advantage by just giving the dose twice a day or potentially even once a day. But if they're a standard metabolizer, mixilotine must be given 3 times a day. And so she was on a wimpy dose given twice a day. She's essentially untreated. So now with starting to treat the mixilotine, what you and I would be watching for is to see, are we measurably shortening the QT interval? So instead of Susie's QTC being persistently above 500, have we shortened it from 510 to 470 to 460 to 440 to a point where now you and I could stare at the ECG and not be able to even suspect the presence of her LQT3 mutation?
That was great. I think especially for all of the listeners, that distinction between, what are we actually looking for when we're treating these patients, and how that changes or should be different between the beta blocker therapy versus something like mixilotine is incredibly useful and very helpful to understand why. So thank you so much for that explanation. Today we talked a lot about the intersection of genetic data, ECG data, and clinical data in accurately diagnosing and managing patients with channelopathies like long QT syndrome. Now we're starting to talk a lot more about integration of artificial intelligence. So just curious, you see a role for AI-based algorithms, whether it's in just interpretation and detection of ECG abnormalities or in risk prediction modeling in this patient population?
Absolutely. And of course, we have to talk about artificial intelligence. How could we get away without talking about it in today's time and frame? And I love it. So the AI ECG. So full disclosure, we have at Mayo Clinic created new knowledge in the AI ECG. For example, we have created a deep learning algorithm, if you will, neural network for AI QTC measurement. So to make the measurement detection of QTC prolongation more accurate, so it doesn't rely on the brain and the eyes. That effort is part of a product within AliveCore's CardioMobile. The QTC feature has been FDA approved for prescription use to turn on the QTC feature. But the next phase that really needs to happen is for it to be FDA approved, cleared as a consumable turn on, just like atrial fibrillation detection is a turned on feature in some of the wearables. So that's the next iteration that's going to happen. And then there's a soon to be published work of ours where we have actually trained the AI ECG to be a long QT syndrome mutation detector. So I think this is really cool. It will come out soon in the Mayo Clinic proceedings, but essentially what it has the ability to do, the AI ECG brain, is to stare at a patient who at least came to Mayo Clinic, a tertiary center, and now they have a QTC value ordered by whoever, podiatrist to electrophysiologist, where that QTC is above the 99th percentile value, 470 for men, 480 for women, as an example. And it can stare at that QTC of 510, like for Susie, and it can give you and I a very high prediction as to whether she's 510 because there's a long QT mutation lurking in the background. And that's without even knowing what drug she's on, what's her electrolytes, or what are any other QT agitating factors present. So just staring at the T wave and all of the data points, 6,000 data points are present in a 12-lead ECG. It can stare at that length, 510, and tell you that is 510 because there's a long QT mutation there versus that is due to a non-genetic acquired reason. So I do think we're going to see some really exciting things happen with the advent and the implementation of AI ECG for QTC measurement and the AI ECG for long QT syndrome mutation detection. It's a pretty exciting time.
Dr. Ackerman, that sounds mind-blowing, both in terms of diagnosing QTC prolongation and also even getting to genetic testing prediction. That's just amazing. The diagnosis and management of channelopathies, as we have seen today, is complex and nuanced, but I think we can all agree you've equipped us with the knowledge and tools to take care of these patients swiftly and appropriately. Thank you for being here with us today and for sharing your expertise. One parting question for you. It wouldn't be a CardioNerds episode unless we asked Dr. Ackerman, what makes your heart flutter about electrophysiology?
Yeah, that's an easy one. The honest answer is I'm actually not passionate about electrophysiology. I love the channelopathies. And so my patients with genetic arrhythmia syndromes, the channelopathies, the cardiomyopathies, they really, their home right now is they end up in the home of electrophysiologists. And that is not a great home. We need to work to find a better home, or at least equip the electrophysiologists who will spend 90 to 95% of their training. Natasha will spend 90 to 95% of her training at MGH in things called everything but long QT syndrome, CPVT, and Brugada. And so what I'm hoping we can do is increase the confidence and competence of heart rhythm specialists so that we can make accurate diagnosis and then, if necessary, recognize when that disease is outside a person's sweet spot and phone a friend. So I am not a heart rhythm specialist. I don't view myself as that. I'm a genetic cardiologist. And so just like I would never think that I ought to do an ablation in anybody or a fetal echo in anybody, we do need to start recognize that these families with the genetic heart diseases of the channelopathies and the cardiomyopathies, which we didn't get to talk about, they deserve their home. They deserve their specialists. And so what excites me the most is to see the field of genetic cardiology starting to grow, to see people start to do what I did in 2000 when I got hired by Dr. Jamil Tajik, when back in the day, Dr. Tajik said, Michael, why should I hire you as a pediatric cardiologist in my department of adult cardiology? And I said, well, Dr. Tajik, I'm not a pediatric cardiologist. I'm a genetic cardiologist. And 25 years ago, Dr. Tajik said, oh, I like that, genetic cardiology. So it is possible, although I can't prove it, that we might have invented the concept of genetic cardiology and the subspecialty of being a genetic cardiologist back then in 1999.
Dr. Ackerman, that was such a great anecdote. Thank you for sharing, and we cannot thank you enough for joining us today. This is one of those episodes where the wait between us finishing recording and its release is really hard. I cannot wait to have this episode released. Natasha and Sonu, thank you so much for leading us today. And this has been another episode of the CardioNerds Beyond the Board series. See you next time.
All right, you guys, that was fun. Thank you.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangas. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.